Good morning, good morning. How's everyone doing? It is Dr. Murphy with Murphy Medical Associates team at coronatestct.com. Thanks for joining me today. It's my very first. Ooh, that's bright. That's bright. That's bright. Is that bright for you guys? That's super bright for me. Let's see if we can soften it up a little bit. Let's just soften color up. Hey, watch out. How you doing? Let's see, this morning, early morning, it is 6:43 on the 23rd, right? It is the glasses. Oh, much better, right? Much better. I can see way better. So here we are this morning. It's around 6:43 a.m. Data and the science, right? For those who don't know, since this is my first YouTube stream, Periscope is going away. I have got hundreds of videos charting my first year's coronavirus. But, you know, I recognize through all of it that I never really talked to anyone on Periscope about what I do, kind of go over my philosophy, right? What's my philosophy? My philosophy in medicine is to be the early warning sign, right? To be the early warning sign. What does that mean? That means we detect before anyone else can detect, right? To treat as early as possible to prevent the worst outcomes of disease, right? And what am I? So I'm board certified in internal medicine. I'm board certified in bariatric medicine, which is weight loss medicine. I also trained in genetics. I was a clinical fellow in genetics at Yale, and I teach genetics for the pathology course at my local medical school. And I teach genetics for the biochemistry course of my local medical school, where I am an assistant professor in the departments of cell biology and anatomy, right? So a clinical doctor working in the cell biology department. That's just for teaching, right? That's just for teaching. My main job is running my medical practices, where I really carry out the goal of this, right? Prevent what you can, diagnose as early as you can to prevent bad outcomes, and not in that order. Lifestyle first. So I'm constantly reviewing the lifestyle literature, the epidemiologic literature out there, as well as literature that athletic trainers have on exercise, the best exercise modalities. In addition to that, I train in genetics. So I look at your molecules, right? That's kind of what I've been doing for years. So when COVID came along, it was a no-brainer, right? I had to diagnose before anyone else. Check, we did that. We had literally the first drive-through testing centers on the East Coast. We were open before any of the hospitals were, right? So check, we diagnosed first. We continue to persist in the field through all of this time. And we currently are testing in 3 counties today. Well, 4 counties, technically. So we continue to provide early diagnosis for patients as best we can, right? That's the goal. And in this case, it's COVID, but also I'm very aware of the complications of COVID, right? I'm really focusing a lot of our efforts on long COVID, but I'm also looking at the sequela when you have the infection and 3 to 4 weeks after infection, right? So the novel coronavirus, SARS-CoV-2, colloquially called COVID-19, right? Because COVID-19 was labeled as the lung infection that happens. It's really not. We've had over 120,000 encounters for this COVID-19 stuff over last year. So what we're really focused on prior to COVID is the same stuff we're focused on during COVID. Prevent, right? Prevent COVID, right? Prevent COVID. And then if diagnose COVID is possible, and then COVID to prevent the complications, right? And so a little bit about what we did before COVID, right? So I was the guy who was putting people who had insulin levels. Why? Because insulin levels matter more than your sugar levels in a standard blood test, right? Your fasting insulin levels are going to tell me more information even than a hemoglobin A1C. So I was the guy putting people who had insulin levels, put them on metformin. I was putting them on a ketogenic diet, right? So and watch their insulin levels. Next, introduce some walking and muscle building exercise, right? So introduce some walking and some muscle building exercise. So go ahead and do that sort of stuff, right? And doing that. We've been doing that for a long time. People for all sorts of weight, you need to lose weight. Okay? High cholesterol and you're overweight, you need to lose weight. Increased risk of cancers, you need to lose weight, right? And so we were having people lose weight, right? That's why my Twitter handle is Take Weight Off MD. That's part of what we do, but almost there because the nation is overweight. So when COVID came, guess what? We knew we were going to have problems. We knew we were going to have inflammation problems. We knew we were going to have cardiovascular problems. We knew that there were going to be worsening insulin problems. There's no doubt about that when inflammation goes up. Close the old little black book here. Let's see. Right. So there's tons of stuff going on with this disease. And so how did I know about it? Well, I'm a researcher, so I can read a study or two. And the first thing I knew what to do was to go listen to the virologists. And so I voraciously listened to the virologists, listened to the epidemiologists. I needed to look at, so we're able to review those things. And I think that was very, very, very important. Like everything else in this world, I do things early, right? So right now, for an example, for our practice, but also for COVID, I have the world's first portable machine, right? We have a portable MRI machine, low field MRI machine. Well, why would you need that? Okay. Well, let's think all the reasons you would need a portable MRI machine, right? If they have COVID, your portable MRI machine to make sure they don't have clots in their brains and strokes, right? So low field MRI with something called a transcranial Doppler, you can see the blood vessels. There we go. My connection was unstable. So when you pair a transcranial Doppler, which is an ultrasound that looks in your eyes, in your temporal, and also in the back of your head, it can look at all the back of your head and they wrap around, right? It's something called the circle of Willis. And so we get to look at those blood vessels. And we can see where the little clots are throwing up in those blood vessels. You see the clots throwing in the blood vessels. So that's an important thing. The second thing is that we use an MRI to look at the brain tissue to make sure you're not having a stroke. We could do this in real time while you're infected with COVID, right? So again, by having all the diagnostic tools, you don't have to go to the hospital. You don't have to go to the hospital. And that's really what our goal is, to keep you healthy and hospital free. So we had some pretty cool tools, right? We also have a laboratory where I do diagnostic testing. Part of the goal was to understand everything about COVID before it came, just like we do with every other disease that we have, whether it's ME/CFS, which we treat, whether it is diabetes, whether it is hypertension, whether it's depression, whether it's ADHD, whether it is cancer, whatever it is, our goal is to dig deep in each condition, right? And so that's what people don't get about a general practitioner, right? We have to treat everything from sinus infections to ITP, chondral diseases or metabolic diseases that most docs don't get to see. Lucky me. Actually, it is. It's really cool because when you study molecular medicine, you then understand how it all interconnects with each other, and it's just amazing. So yeah, where was I? So before COVID, I was doing a lot of what we call diagnostic work. Our practice in Greenwich is called Diagnostic and Medical Specialist at Greenwich, right? we were using advanced tools, molecular medicine tools, genetic testing tools, advanced ultrasonographic tools, especially our vascular. Our vascular ultrasounds are the best, right? So that's looking at your blood vessels. We looked at autoimmune stuff, right? So we'll look at metabolic stuff as well. The body screaming out when you're under stress, right? And they change according to your stress levels. So it really gives us some insight into the patient that most traditional docs would never order, right? They would never order these things because they don't know how to interpret them. They don't understand the physiology of it. Why? Because they took physiology in medical school. They're no longer teaching in medical school. So you kind of lose your knowledge base erodes. Your knowledge base erodes. And so we've always advocated for sharpening the saw. We've always advocated for sharpening the saw. We've always been the early diagnostic guys. That's us. That's us. That's who we are. It's who we are. Always ahead of the diagnosis. Always. I poured through the literature. And I found case studies of different lab abnormalities. I compiled a lab diagnostic panel together, right? And what was interesting is it was similar to my physical exam panels where people come to me and say, I just don't feel right. Why? The body was under stress. But I didn't know whether it's just from stress or whether it's an infection from COVID. It infects the lungs, it affects the heart. We have cardiomyopathy, so ultrasounds of the heart are essential here. It causes your blood to congeal, leading to increased risk of clots. So ultrasounds of the neck and the brains, right? These are huge things to do. It can really mess with kidney function, and microemboli go into kidneys. We've found that in children, even with mild disease, even with mild kidney dysfunction. Why? Little tiny clots, right? So it's not good for really try to prevent. Wait a second. Haven't you been? Yes. We have been studying prevention literature for a very long time for a wide range of diseases. Here are the tips to prevent getting COVID. You ready? You ready for the tips? You ready for the tips? I'm going to give you the tips. Let me give you the tips. Okay. There are a couple things you can do with COVID, right? So let's talk first about direct prevention. You're in a space with someone who has COVID, right? Let's say you're in a space with someone who has COVID, right? Man, this ended up so bright. I know it's up so bright. A little bit better, guys. A little bit better. It's so bright here. You get excited. You get these tips. Get these tips for COVID prevention. Step one, socially isolate, not be around anyone. Sit on your own private island, get DoorDash or Grubhub and Instacart or Peapod or whoever else is going to deliver all your stuff, right? And you can work remotely. So there's a subset of people that can just work remotely. They live in their homes, they exercise in their homes, they work in their homes. They don't talk to other people other than like on the YouTube or on Zoom, or now this interesting thing called Clubhouse. I think it's pretty cool. I'm on Clubhouse. I've still got to figure it out, but so you can do that. If you can't do that, and you have to be in a space with others, the first step is to limit your others to a smaller. If you can work with the same people, that's great. Hold those people to the same standard that you have. Hold them to the same standard. So what does that mean? That means listen, people, we're only as strong as our weakest link. We're only as strong as our weakest link, right? So you've got a cohort, you've got a bubble of people that you with. So by interacting with those people, you mitigate your risk by all holding each other to the same standard. Now I'm going to talk about the rest of that standard, right? The rest of that standard. In the space, if you're indoors, you should have the following things. Here, I'm going to get one of them up. Let's see if I can plug it in. I'll show you guys. The light's too bright. Light's too bright, right? I'll send you a picture of it. I'm going to pull it back. You can't see it because it's too bright. All right. So this right here is an air quality sensor, right? So I believe that all indoor spaces should have an air quality sensor. All indoor spaces. I think that grocery stores should have these. I think that retail locations should have these. I think schools should have these. And regularly, when the air quality goes to open the doors and windows of whatever the place is, let it air out. Let it air out and change the air, rotate the air over. So there, where I got this? I got this little quality measure here in the background. I'm going to measure the air quality, right? Number two, have some sort of successful humidification strategy in your space when the air gets dry. When the air gets dry. You know, Akiko Iwasaki at Yale and several other environmental scientists are studying virus transmission through air. And here's what we found. Novel coronavirus travels. So like I said, Akiko Iwasaki at Yale and other virus researchers, as well as environmental scientists, have found that novel coronavirus travels like droplets. But if your humidity drops under 30% in the 20% range and lower, the virus is airborne. And humidity under 40% causes airborne. I don't know what to say. My connection is unstable. Here we go. Dry winter air causes airborne COVID. All right, dry winter air causes airborne COVID. Keep the air in your spaces with the people you work with humidified. Keep the air in your homes humidified. Now we have to talk about a mitigation strategy when COVID is in the air, right? 2%. Next. You need HEPA filtration. Okay, this is high efficiency purification systems. In big grocery stores, you need air filters that are MERV 13 to MERV 16. MERV 13 to MERV 16. It's a rating, it's a mechanical rating of the proper ventilation and the proper purification of air. In your homes and in small workplaces, you don't need MERV 13 to 16s. Instead, you need HEPA filtration units, right? HEPA filtration units. And you need to put those units in the proper square footage. You can see that on the box. You can see that on the box of the filtration unit, where you can see it on the box of the filtration unit. To add additional protection, look for UV purification. Ultraviolet, UV, ultraviolet purification. Okay, next. When you're working with other people, keep social distant if you can. One of the things we found that happened in the meat packing plants, and when we were testing for Lockheed Martin, working in close assembly lines, you can't socially distance. You can't socially distance. A good example is the meat packing plants, okay? The meat packing plants they're cold and dry. They're the perfect storm for spreading virus in close quarters. All of those people should have had N95s on. All of those people should have had N95s on. And there will be lawsuits. There's no doubt about it. There's no doubt about it. All of those people in those meat packing plants with the first outbreak, they should have been put in N95s. You should have found a humidification strategy that worked best. So let's say you work in an office cubicle. Most of those people had been working from home, but the problem is their productivity wasn't so good. So their bosses brought them into work. Okay. Okay. All right. So mark some X's on the floor and keep yourself at least 6 feet apart. At least 6 feet apart. That's some risk mitigation. 6 feet will work if your air is humid. If your air is not humid, it won't work. It won't work. It all starts with humidification. Humidification, air quality monitoring. Everywhere. Everywhere. That's what should be happening. Humidification, air quality monitoring. And then purification and circulation, right? Open the doors, open the windows. If you can't open the windows, you better have good purification techniques. So those are ways in spaces to keep from getting the novel coronavirus. Wait, you didn't talk anything about fomite transmission and wiping stuff down. Yeah. You should do it, but you shouldn't freak out about it. You should do the following. Don't touch your eyes. Don't pick your nose, right? Don't pick your nose. And if you have to touch your face, wash your hands first. I tell all my kids, wash your hands first if you've got an itch on your face. When you're done washing your hands, often the itch goes away. Often that itch will go away. And then obviously your iPhone, hello, right? So your iPhone is a bundle of germs. It's a bundle of germs. So wipe it off. Wipe it off. Use an alcohol sanitization wipe to wipe it off. Wipe off your phone. Take care of it. So that's the surface that you touch all the time. Surfaces that you're touching all the time, yeah, it's reasonable to wipe them down. It's totally reasonable to wipe them down. That will help you out. But going to the grocery store, getting takeout food, and you probably don't need to wipe it down. You can. It's not going to kill you, but you probably don't need to. You probably don't need to wipe it down. All right. So that's the old wipe down method here at the workplace. When you get home from work, shower. I tell you what I do, right? If I'm working in the hospital, right, when we have hospital patients and round on them, when I come home, I take off my dirty clothes. They go in the wash. And I hit the shower. And I hit the shower. If you don't have the time, disinfectant spray in your hair. How I said, listen, contact and all that other jazz, spray your hair. Or put a little UV light in your hair. Or if you can't take a full shower, wash your hair. All right, why? Because you're going to touch your hair and touch your face. Not touch your face. Get it? Not touch your face. So I think I've gone through a lot of prevention. Wash your hands using alcohol sanitization strategy when you can't wash your hands. This is the stuff that we talk about with our patients when they get their blood drawn. Prevent this disease. Vitamin D. Vitamin D improves your immune system. 2,000 to vitamin D3 by itself. Not vitamin D2, right? Not vitamin D2. We have to be careful with how much vitamin D we give ourselves. I can tell you, back in June, I gave myself a kidney stone. Gave myself water. There's your dietary advice for the day, right? Don't drink so much coffee, drink more water. You need 64 ounces. That once you drink it, you have to pay it back plus some. you got to pay it back plus some. That's part of the deal. Part of the deal. You got to pay it back plus some. All right. So that's preventative care stuff for vitamins. We could talk about when you get it and create a hostile environment for upper respiratory pathogens. So vitamin D plus zinc, we found are really good things. The evidence behind having more severe disease and low vitamin D as an association is real. It's there. So don't let your vitamin D levels get low. Keep them up. Don't let them get low. Keep them up. So if you can keep your vitamin D levels up, you're doing okay. So where are we? Vitamin levels. Well, vitamin D is actually a hormone. So we test hormones in our blood work, right? So people who have low testosterone, oh no, again. Unstable. A little more coffee. Oh, hey there. Right. So we talked about hormones and vitamin D. Men who have low testosterone levels have worse outcomes with COVID. They have more critical illness. So looking at testosterone levels and blood work, we talk about the assessment after. I'm going to go through this. I'm probably going to put you through my first live stream. I normally do periscopes. Again, Dr. Murphy, Murphy Medical Associates, and our team at coronatestct.com. coronatestct.com. So we also have coronatestnyc.com and coronatestny.com for the patients we test in New York City and the greater New York area. Right. So vitamin D is a hormone. Check. When you're infected, take zinc. Check. Other preventative stuff. So I'm going to get a little bit into the weeds and speak a little bit out of school from the powers that be, whatever the heck those are, right? I'm an academician. I am also a clinician, and I recognize the difficulty of running a private practice. So what you need to understand about physicians is there's all kinds of physicians. There's all types of plumbers. Many different temperaments, talents, and convictions are what make for greatness in the United States. To call it a melting pot, I propose that the United States is a good gumbo or stew. It's a good gumbo or to have the sauce taste on them, but also they're different, right? They're different. The sausage versus the shrimp. Doctors are smarter than others, even though that happens, right? In academia, what happens is a diminution of the capacity of physicians that are not in academia. And I find that to be atrocious, right? It's absolutely unacceptable. Physicians are required to do continuing medical education every year, right? They have to do continuing medical education every year, right? So they have to continuously learn. Good physician, academia. I know bad physicians in private practice. The rate's about the same. Intellectually curious physicians or intellectually lazy physicians. Intellectually lazy physicians tend to just wait for, actively go out and they look for unstable. They look for the data. They look for the data. Whether you're at an academic center where they read the data and find what's missing and go research the data for more data, or they read everything, find out what's missing. The calculation determines whether or not you use a treatment or you diagnose people with different modalities, right? CT scan has radiation, right? I mean, you could turn it up really high and get ultrasound burns. No one does that. Okay, no one does that. And most machines, most ultrasound machines have what we call prevent you from getting at a frequency that can hurt the body. The only place you have to be very careful is when you ultrasound the eyeballs. When you ultrasound the eyeballs, you have to be very careful. And yes, I know I touched my eye, right? But I washed my hands before. MRI is not going to, portable low field MRI is not going to give you the same problem. Low field MRI will not give you the same problem that happened at low field MRI. It's a portable MRI. It's low risk. Drawing people's blood is low risk. It's actually higher risk for the patients, right? And in fact, every time we had to gown up in PPE, that's a complicated phlebotomy. It's a complicated phlebotomy. And so it requires all of this gear, which makes it harder to draw blood, but you're in the face of someone who has COVID. So you're spending a lot of time with them. So that's a high risk phlebotomy. I'm separated, doing it outdoors. Risk benefit calculation. So what I like to do with my risk benefit calculation is simple. Toward effects. If that risk is high, then you have to say, will the medication benefit the patient? That much higher. See where I'm at? You see the difference? That much higher if the risk is high to hurt the patient. Conversely, if the risk hurting the patient is low, right? It's low, it has to be this much higher. The evidence for benefit has to be this much higher because I'm not hurting the patient. I'm not hurting the patient. Okay? It always has to be higher. It always has to be higher because you can't have, we treated people with hydroxychloroquine in the beginning. We did. And anecdotally, I think we saved lives. Anecdotally, right? We have been through the 120,000 encounters in our system. Me 5 cups of coffee a day. Have to. If I continue live streaming, I have to make sure that the connection is better. I got to figure out. Yes. So we give people hydroxychloroquine. I think we saved lives. If I was a Google conspiracy theorist, I would say every time I use the word HCQ, that Google's popping up an unstable thing, right? It can hear it, and so it flags it. So we gave it to them. Anecdotally, I think it helped. I have patients who swear that I saved their lives with it, right? One of them's a great police officer, actually, detective. So high quality studies showing that it doesn't help people in the hospital. Actually, about the drunk and the light post. The drunk and the light post. Never heard it? Haven't heard it? The story goes like this. A drunk is walking circles around a light post, looking for his car keys. When his buddy comes out, hey, I'm looking for my keys because I had to drive home. His buddy goes, well, why are you just looking around the light post? And the drunk goes, oh yeah, because that's where the light is. That's where the light is. Surprise that academic centers, big hospitals are set up to do research with the hospitalized patients. No. That's where the light is. That's where the light is. Inpatient or at a large academic center. Just are. Large academic centers are not set up to do private practice, outpatient treatment. They're set up as hospital systems that have gradually scaled up. Unfortunately, their physicians do not, their outpatient physicians don't to do research on an outpatient setting, affect outpatient trials, for outpatient trials. So the reason I'm giving you all of this is because the Frontline Critical Care Consortium managed to assemble data from outpatient studies of healthcare workers. What did they find? Well, they did studies looking at a medication called ivermectin. Ivermectin as a prophylaxis. We can get into the pharmacology of it in another YouTube. Prophylaxis was found effective in healthcare workers, was found effective in Italian healthcare workers. Prevention for infection. Prophylaxis is what we call it. From the novel coronavirus was their recommendation to not use ivermectin. Good job, Pierre Corey and the FLCCC. They have instead left it up to the clinician's discretion. Okay? Left it up to the clinician's discretion. Well, what is ivermectin? Is it a safe medication? Ivermectin is used for scabies and lice, okay? Parasites, for river blindness, and I said for scabies. Is low. Risk for benefit. Well, what would be a benefit? Preventing getting the coronavirus infection. Something mRNA vaccines. There's no guarantee that you won't get infected with a vaccine that is currently out. Okay. You just won't get severe disease. All right. So what do we do for prevention? Well, we do all of these low risk mitigation strategies we talked about. Maybe now we add ivermectin. The evidence for, remember, if the risk is low damage, they're in packed spaces, take ivermectin for prophylaxis. Maybe they do. Add it to the armamentarium. Not hydroxychloroquine, right? The data is still going to have to come in on hydroxychloroquine, although we do have another study which shows that because the infrastructure to research on an outpatient basis is not as good as an academic center. So we had a whole year where we could have used evidence, not the best evidence, but evidence, like the ivermectin story. We could have used that for at least the last 6 months. We could have used that to prevent disease. The CDC didn't allow it. They said, nope, don't do it. So the intellectually lazy doctor didn't do it. The intellectually lazy doctor didn't do it. The intellectually curious, they didn't use it for fear they would lose their medical license. They didn't use it for fear that the powers that be would take away their medical license and call them crazy. Take away their medical license and call them crazy. They're not crazy. There was evidence, and they did the calculation. Simple calculation. Risk is low, right? Risk is low. Evidence for benefit is a little bit above it. It's a little bit above it. But I forgot the last risk, right? That's the political risk. The political risk was high, so no one did it. With the CDC changing its recommendations, it pulls the political risk down a little bit lower. You still have the risk of getting attacked by other academic physicians who say, the bar isn't this high. Well, no, of course it's not that high. We need years of data to get it that high. Risk is low. Low risk. Low risk. Okay, low risk. Meanwhile, the same people that are saying that are telling you to go get a vaccine, which does have low risk too. Nope. Okay, so here we are. I opted for prophylaxis. I think this is not individualized medical therapy for you. Okay, that's not individualized medical therapy for you. I'm not engaging in a patient-doctor consultation over YouTube. No. All right, and I'll put that in my show notes afterwards as well. All right, so medical prophylaxis with ivermectin. Perhaps if you're in packed spaces, we consider it. It's time to put up there in our armamentarium, right? So now we've worked to prevent novel coronavirus as best. Even with all of that, and that's a lot of stuff I threw out there, even with all minutes to present to you, maybe I'll go a little bit longer, how to keep yourself out of the hospital. Boop, 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 boop. Oh yeah, hi, hey there. I've been told that my connection is unstable, so hopefully it's a little bit better. All right, where are we? Ah, yes, we were talking about despite all your best efforts. So now we're still back in the paradigm. Prevent the untoward outcomes. Prevent the untoward outcomes of the disease. Treat early, outcomes as early as possible. Diagnose early the complications so that way they don't build up in your body and kill you. So they don't build up in your body and kill you. So let's think about that. Also, we're going to keep you out of the hospital, right? The goal is to keep you out of the hospital, out of the hospital. That's the goal. So how do we do that? We look for the earliest diagnostic signs of complications. We do that through blood work, even outpatient novel coronavirus. Again, I will hammer on Akiko Iwasaki, but what we were seeing from our blood work panels that we were doing back in April and May didn't make a lot of sense. We had case studies of prostate antigens going up, tumor markers going up, hormones going all over the place, testosterone levels being off, a thyroiditis, a thyroid virus. Of course, the lung stuff, the lung infections and the pneumonias, stuff with the pneumonias, and then a myocarditis, infection of the heart, and a pericarditis. Oh man, this connection thing is the worst. The connection thing is the worst. So I said pericarditis of the heart, cerebritis, right? We were seeing people, they couldn't smell. So that meant we couldn't quite figure it out going across the blood-brain barrier. We were finding kidney failure. Kidney failure, yes. It was infecting your genitourinary system, your kidneys, your bladder, and your prostate. If you're a man, if you're a woman, you don't have prostate, we don't need to check your prostate. So all of those things we were seeing in our blood work, it was terrible. It was remarkable. In addition, we saw sequestering of iron. So this is why people thought maybe hydroxychloroquine worked, because maybe this was like a malaria type condition, right? They were sequestering iron, but your ferritin levels were going through the roof. So that means you were inflamed, right? So we're checking ferritin levels, LDH levels to see how bad a disease you were going to get. Then we added on certain pro-inflammatory cytokines like IL-6. And then when we did that, the evidence was soft. But now we found ratios of IL-6 to IL diagnostic criteria, so we know when people have bad disease and when they need to go in the hospital. One of the simplest ways to do that is with this device right here. You guys can see what this is. So this, so you can see it. Keep it out of the light. See that there? I've had enough coffee, so my heart rate's probably through the roof. I could get it better at HD. This says it's HD. This is not HD, right? This is not HD. This is a pulse oximeter. This will save your life. 3 times a day, report nurses to our nurse practitioners, to our PAs. This is why our mortality rate, and I hate the unstableness. Okay. Our mortality rate in the first wave was 0. 0. We had no one die in the first wave because they had a pulse ox. See, I have mine in a little container right there. It's a good little container. The pulse oximeter was essential to monitoring early disease. And in fact, what's up, big guy? Who else we got here? Wavy James. I don't know who Wavy James is, but Wavy James is a big deal on Clubhouse. Congrats. Maybe it's just because I'm an old dude that, who knows? Anyways, when we were able to do blood work, we were able to identify all sorts of problems in people. But I had to convince my ultrasonographers to suit up in Tyvek suits and ultrasound the infected. You know what we found? We found clots. We found a lot of clots. So we gave patients that had an elevated D-dimer ultrasounds looking for clots. And when their D-dimer was up, we gave them Lovenox. Okay, here's where risk is high. But the evidence of giving Lovenox to prevent clots is even higher, probably up here. All right, probably about up here. Even high pulmonary emboli. I'm pretty sure we did. So you're infected, you're treated, your doctor, your nurse practitioner, your PA, checking your pulse ox 3 times a day. 3 times a day. Next, we're boosting your vitamin D levels, but we're checking your vitamin D levels. So a lot of the patients, they could home visits for blood work to check vitamin D levels. Why did we check vitamin D levels? Because I didn't want them to get a kidney stone like I gave myself. Reduce the risk. Draw the blood work, reduce the risk. Draw the blood work, reduce the risk. And so to this day, we still check vitamin D. Overrun it. Totally going to overrun. Draw blood work. You've got COVID, get your blood work checked. And this is all about early detection, right? It's all about early detection. So we do it for heart disease. Why wouldn't we do it for COVID? We do it for heart disease. We do it for cancer. Why we do it for COVID? So we do ultrasounds of the kidney vasculature to make sure you don't have clots. We do an ultrasound of the heart when you have shortness of breath, or these novel pods, these care pods, where a patient can go with good ventilation and good UV light sanitization to get an ultrasound. Right? So we echo the heart. We take a look at the heart. We look at the brain. We look for clots there. We look for clots. Earlier diagnostics that are available, it will overwhelm the hospital. It'll overwhelm the hospital. And we see that already. Look at Los Angeles. I mean, one of the shocking statistics is the following. Once ICUs and hospitals are overwhelmed, the ICU mortality in Los Angeles County went from 13%, which is still pretty darn high, to 23%. That's like almost a doubling of mortality because they were overwhelmed. They were stretched. They didn't have the resources. It then becomes battlefield medicine. It then becomes battlefield medicine. What do you want? Our goal is to keep people out of the hospital. And one of the ways to do that is to do it our way, right? Do it what we've done for best practices, right? What we've done for best practices. So we take a look at the heart. Take a look at the brain. We look at your carotids and we do a transcranial Doppler, right? Where we look in your eyes. There you get an MRI of your brain. You get an MRI of your brain. If the clot levels go up, if the D-dimer levels go up, we give you blood thinners. If your D-dimer levels were below 2.5 but elevated, we give you aspirin. Right? We give you aspirin. If you're above 2.5, we give you Lovenox or novel oral anticoagulants, depending on what we find. Right, depending on what we find. Let's talk about other treatment, right? We boost your zinc levels with units of vitamin D3 with K2. With K2 because we found the risk. Otherwise, you put yourself at risk. The FLCCC, the Math Plus protocol are things that we're actively investigating as we wait for the evidence to build. That's what we weigh here. I think the tide will turn with early outpatient treatment. It's a no-brainer. Vaccines don't even fully protect from all of these long COVID patients. So my next stream I'm going to figure out, we're going to do live streaming probably at least once a week. I'm going to try to live stream and how we treat that. So now we can do anticoagulation. Right? If your sats get really low, we give you at-home oxygen. At-home oxygen. and we teach you how to, sleeping on your belly helps open your lungs. It helps open your lungs. This is what they're doing. Pneumonia, prone belly sleeping. For that, I want to talk about something else. Monoclonal antibodies. Now, the monoclonal antibodies by Regeneron or Eli Lilly, especially Eli Lilly with Bam Bam, which starts to appear to be the best in class, are highly like the vaccine, but only if early diagnosis. If you can't get an early diagnosis, I'm going to give you a case study. My mother develops a fever. I call her immediately and I say, what the hell? Hi, just refilling. So I call my mom and I say, what the hell? You've had a fever for 3 days and you didn't tell me? Well, you know, I kind of get fevers. How high is it? 103. What? You have a fever of 103 and you didn't call me? Well, I didn't want to worry you. You need to get tested today. Well, I don't know where. She is 20 and she can't navigate how to get a corona test. I tried to call my doctor. There's no answer there. Great. Okay. Call your doctor. I'm going to get on the website for Gulf Coast, Florida. Here are 30 places to call on the Gulf Coast near Tampa to get tested. Can you do that? I call my team. I said, forget this. I'm taking it out of her hands. I'm going to go pack up our swabs and ship them to her. Pack them up, ship them to her. Done. Boop. Out. Out. Ship them via UPS. Hey, Mom. Yes, I can get tested on Friday with a 3-day turnaround time. You won't get your result back. You won't get your result back to the following Monday, and you probably had it 2 to 3 days prior to that. That'll put you at day 9. You'll miss monoclonal antibodies. They get the samples. Father and mother swab each other. Right? They swab each other in a demonstration of love for each other. They pack up the samples, freeze and pack, ship them back to me. Positive. Both monoclonal antibodies. They'll get their antibodies on Monday. Day 9. They never would have been eligible. My mom, day 9, maybe my dad, day 7 or day 6. They never would have been eligible for the antibodies, the monoclonal antibodies from Eli Lilly, if they had been tested at home. If they had to wait days to get tested. Wait days. At least I could overnight them swabs and get them back. This is where Michael Mina makes sense, having test kits at home. Test kits at home. Essential, right? I agree. Essential. Even if you miss stuff, having kits at home for regular testing is great. Jonathan Rothberg is working on that as well. Testing at home is essential. Paired testing, antigen and PCR, very reasonable to do. Very reasonable to do. I'm not going to get into cases that people are calling it a false positive. It's not a false positive, dude. It's a false infectious positive. False infectious positive. It's not a false positive. You don't have novel coronavirus, SARS-CoV-2, RNA in your nose unless you got the virus or had the virus, right? It's just not there. It's not there. You're not going to find it there. So ramp up your cycle time, shrink down your cycle time. It's evidence that you had a robbery in the house, right? Someone came in your house and robbed you. So you got to look for the effects. What did they do? What did the gremlin do? What did that gremlin do to you? And that's long COVID, and that's a talk for another day. Done. All right, so in this case, parents come back positive. I've got them on vitamin D. I've got them on zinc treatment. Ivermectin in critically ill cases. Pierre Corey has reams of data on that, and frankly, we should probably be doing that. ivermectin for severe cases in critical care. Evidence is starting to add up for that as well. Evidence is starting to add up for that as well. All right. Evidence is not adding up for Tosi, right? Tocilizumab, bundles of money, way more expensive than ivermectin. Crappy evidence. So, lift some weights, take daily walks, get sun, get fresh air. It's just good preventative care. But it also is essential in the patient who has COVID. Also essential in the patient who has COVID. I already talked about how to keep other people in the house from getting COVID through our environmental mitigation strategies. But you got COVID. You got COVID. You're isolating in your room or your area where you can have proper ventilation, trying to keep it away from the rest of the family. Household infection rates could be as high as 40 to 60%, right? Depending on the variant, which is a talk for another day as well. It's a talk for another day as well. So we're treating for COVID. We're looking at your markers, and you can't just test once. You got to do blood work in kind of a series. So you do it in week 1, you see where they're at. You do it in week 2. Remember, once you get out of week 2, it's no longer the virus that's got a hold of you. It's your inflammation. In critically ill patients with COVID, in this unstable. Steroids with Decadron, dexamethasone. Don't give steroids early, give steroids late. Give steroids late. Give monoclonal antibodies early. Personally, I also think, right, make sure you get vitamin D and zinc early, even before you have the disease. Vitamin D at least. Vitamin D at least as a preventative. We're treating it. You're doing your pulse oxes on a daily look. Okay, you got your blood work done and your inflammation is up, but you're not making clots. So they didn't give you aspirin or Lovenox or a novel oral anticoagulant as an outpatient. When do we see clots? Week 2, week 3, or week 4? Should you get your blood work done again? Yes, you should. In the house, we should at least do the blood work weekly. Weekly blood work to see where the people are at. And that's what we recommend at our offices. Weekly blood work. That's a recommendation. That's what I think you should do. And that can keep you out of the hospital, and we'll treat accordingly. Well, there's 3 minutes left until the witching hour is done with my lovely stream here. I'm really happy about it. I got to figure out how to edit and do all sorts of crazy things with my stream to make sure it looks good. I'm now on YouTube. Congratulations, Google. Congratulations, San Francisco. You ruined pizza. Right? So here I am, YouTube, trying to carry this out. I think what I will do, I don't know what this part is, but I think what I'm going to do is we'll try and set a stream on a weekly basis, right? I may set streams down long term and do all sorts of other stuff with them, but I'm probably going to set up a streaming basis weekly. Find me on Twitter at TakeWeightOffMD. Or my medical practice at 1 Murphy Medical. At 1 Murphy Medical. Or our team at coronatestct.com. That's coronatestct.com, right, New Jersey too. We found the first UK variants in Westchester County. Don't sleep on this. It's in Fairfield County too. At the lab we work with, the Grubaugh lab and Yale School coming in. We're getting it. The New Haven County ones came from travel. Unstable connections. All right, so that's the limitation with YouTube. Regardless, we're winding down the hour. It's Dr. Murphy, Murphy Medical Associates. I love you guys. That's right. I love you guys. I'll say it again. I love you. Hug them all. I want to say thank you all for my first Periscope. It's Dr. Murphy, Murphy Medical Associates. Can't even close out right. Nice comments. I can't even close out right. This is Dr. Murphy, Murphy Medical Associates, and our team at coronatestct.com. All right. Sending you all off, saying I love you. And to my Disney peeps, stand clear of the closing doors, please.